Helicobacter pylori and duodenal ulcer. Introduction. Helicobacter pylori, H. pylori, is a spiral-shaped gram-negative microaerophilic bacterium that colonizes the gastric mucosa. It is a major pathogen associated with various gastrointestinal disorders, including chronic gastritis, peptic ulcer disease, gastric adenocarcinoma, and mucosa-associated lymphoid tissue, MALT lymphoma. The bacterium is strongly linked to the development of duodenal ulcers, accounting for up to 90% of cases. Characteristics of H. pylori. 1. Structure: spiral shape with flagella for motility. Produces urease, which neutralizes gastric acid by converting urea into ammonia. 2. Pathogenesis: colonizes the gastric antrum and produces virulence factors, e.g., urease, cytotoxin-associated gene A, CAG-A, vacuolating cytotoxin A, VAG-A, that cause inflammation, disrupt the gastric mucosal barrier, and increase susceptibility to acid damage. 3. Survival mechanisms: neutralizes stomach acid via ammonia production, evades immune response by residing in the mucosal layer. Pathophysiology of H. pylori-induced duodenal ulcer. 1. Colonization and inflammation. H. pylori colonizes the antral region of the stomach, where it triggers an inflammatory response by releasing chemokines and cytokines. Inflammation reduces somatostatin levels, increasing gastrin production, leading to hypersecretion of gastric acid. 2. Acid hypersecretion. Excess acid is delivered to the duodenum, overwhelming its buffering capacity. This damages the duodenal mucosa, predisposing it to ulcer formation. 3. Mucosal damage. H. pylori toxins, CAG-A and VAC-A, and enzymes, urease, proteases, lipases, directly damage the gastric and duodenal epithelial cells. Chronic inflammation weakens the protective mucosal barrier, allowing acid and pepsin to erode the mucosa. Above 4. Duodenal metaplasia. Prolonged acid exposure leads to gastric metaplasia in the duodenum, providing a niche for H. pylori colonization and further perpetuating ulceration. Clinical features of duodenal ulcer. 1. Symptoms: epigastric pain, burning or gnawing pain that improves with eating and worsens 2 to 3 hours after meals. Nocturnal pain, frequently wakes the patient at night. Nausea, bloating, or early satiety. 2. Complications: bleeding, hematemesis, vomiting blood, or melena, black tarry stools. Perforation: severe sudden abdominal pain with signs of peritonitis. Obstruction, due to chronic scarring and swelling around the ulcer. Penetration: ulcer eroding into adjacent structures like the pancreas. Diagnosis of H. pylori infection and duodenal ulcer. 1. Non-invasive tests. Urea breath test detects urease activity of H. pylori. Stool antigen test detects H. pylori antigens in feces. Serology detects H. pylori antibodies but does not distinguish active from past infection. 2. Invasive tests during endoscopy. Rapid urease test, CLO test, detects urease activity in biopsy specimens. Histology, microscopic examination of gastric biopsy to identify H. pylori. Culture, isolating H. pylori for antibiotic sensitivity testing. 3. Endoscopy findings. Ulcer crater in the first part of the duodenum with inflamed surrounding mucosa. Biopsy is often performed to rule out malignancy in gastric ulcers, but is usually unnecessary for duodenal ulcers. Management. 1. Eradication therapy for H. pylori. Standard first-line triple therapy: proton pump inhibitor, PPI, meprazole, esomeprazole, or lansoprazole. Clarithromycin, 500 milligrams twice daily. Amoxicillin, SMR 1 grams twice daily, or metronidazole in penicillin-allergic patients. Duration, 10 to 14 days. Alternative therapies include quadruple therapy with bismuth, PPI, tetracycline, and metronidazole. 2. Adjunctive measures: antacids for symptomatic relief. H2 receptor antagonists, ranitidine or famotidine, to reduce acid production. Lifestyle modifications: avoid smoking, NSAIDs, alcohol, and stress. 3. Management of complications: bleeding, endoscopic hemostasis using thermal coagulation, clips, or injection therapy. Perforation, emergency surgical repair. Obstruction, balloon dilation or surgical intervention in refractory cases. Prognosis: with proper eradication of H. pylori, the recurrence of duodenal ulcers is significantly reduced. Complications like bleeding or perforation require prompt treatment to prevent mortality. Prevention. 1. H. pylori eradication. Screen and treat in high-risk populations or patients with a history of PUD. 2. Avoid NSAIDs. Use alternative pain relievers in at-risk individuals. 3. Prophylactic PPIs in patients requiring long-term NSAID or aspirin therapy. Conclusion: H. pylori is a primary cause of duodenal ulcers, and its eradication has revolutionized the management of PUD. Early diagnosis and treatment are crucial to preventing complications and improving outcomes.